Patients here.
Oh boy, got some blood going.
Yeah, there's never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, and she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the deep dive. We are shifting gears today.
A little bit of a different focus.
Yeah, exactly.
Yeah.
Usually when we talk about emergency medicine or, critical care in pediatrics, everyone wants to talk about the high drama organs. The heart, the lungs, the brain.
Oh, absolutely. The glamorous stuff.
The glamorous stuff that beeps on the monitor.
They certainly get all the glory in the textbooks. Everyone wants to interpret the ECG or manage the ventilator.
So lately. But today we are focusing on the unsung hero, the body's largest organ, the skin. And honestly, for a lot of nursing students and even experienced nurses, the skin is, well, it's an afterthought.
It's seen as just the wrapper.
It's just the wrapper, right, until it isn't. I've heard it described as the check engine light of pediatric nursing.
That is a perfect analogy, but I'd take it a step further. It's not just a light, it's the entire dashboard.
The dashboard, I like
Yeah.
that.
In pediatrics, the skin is often your first clue, sometimes your only clue, that there is a systemic issue, a raging infection, or, a severe trauma occurring. If you ignore the check engine light, the car breaks down.
And if you ignore the skin findings in a child,
The child crashes. It's that simple.
So here is the setup for today. We are treating this deep dive as a specialized exam cram session. But I don't want the superficial flashcard version. I really want the why.
The deep mechanics of it.
Yes. We are imagining our listener is stepping into the shoes of a nursing student right before finals, or a nurse prepping for their pediatric certification. We need to be rigorous.
And we are going to cut through the noise. We're going to look at Chapter 23, integumentary disorders and the drug protocols. But we aren't just reading the list. We are applying the Pareto principle, the 80-20 rule.
Which means we are identifying the 20% of skin concepts that show up on 80% of exams and are critical for safety. I'll play the role of the ambitious student who wants the cheat codes but also demands to understand the mechanics. I'm not just going to nod along. I want to know why the physiology works the way it does.
And I will play the clinical educator.
Mm.
My job is to filter the list, focus on safety, assessment priorities, and explain the pathophysiology so you don't have to memorize it by rote.
Okay, let's dive in. Section A, the master 80-20 map. When you look at the integumentary system in kids, it can feel like a laundry list of weird Latin names. Tinea this, dermatitis that. How do we organize this into big buckets so we don't lose our minds?
You have to categorize them or you will get overwhelmed. In the source material we have today, everything really falls into 4 distinct patterns. If you can recognize the pattern, you can predict the test question and the clinical intervention.
Okay, lay out the 4 buckets for me.
Bucket 1 is infectious patterns. This is your biological warfare section. Bacteria versus fungus. Think impetigo versus ringworm. The exam priority here is almost always contagion control. How do I stop this from spreading? And of course, identifying the rash by its visual description.
Contagion and description. Got it. Bucket 2.
Inflammatory and allergic patterns. This is where the body attacks itself or overreacts to the environment. Eczema and diaper dermatitis are the big ones here.
And the priority there isn't so much life or death.
Not in the immediate sense, no. It's symptom management, comfort, and a huge amount of parent education.
Right. Okay, what's bucket 3?
Hormonal and developmental patterns. This is primarily acne vulgaris. Now, you might roll your eyes and think acne is low stakes, but the exam priority here is the psychosocial impact on the adolescent and medication safety.
Medication.
Specifically, there are some very dangerous drugs used for severe acne that show up on exams constantly. We have to know them inside and out.
And the 4th bucket. I'm guessing this is the scary one.
This is the scary one. Trauma and emergency patterns. This is burns. This is the highest stakes bucket. This is where skin issues become life-threatening airway and circulation issues.
So if I'm looking at this stack of papers and I'm panicking because my exam is tomorrow, What is the can't miss list? What absolutely must I know to be safe?
Okay, cut to the chase. If you remember nothing else from today, you must master the management of burns, specifically the prioritization of airway and fluid volume, and you must master the safety protocols for severe acne medication, specifically isotretinoin or Accutane.
Burns and Accutane.
Those are the two areas where a wrong answer or a missed assessment leads to significant harm or death. Full stop.
Okay. Burns and Accutane are the heavy hitters. We will definitely spend a significant amount of time on those. But let's start with the stuff that you see every single day in the clinic. Let's go to that first bucket, infectious pattern.
Let's do it.
Topic 1, impetigo. Even the name sounds unpleasant. It sounds like something a goblin would have.
It is unpleasant. It's the classic bacterial skin infection in kids. It's incredibly common.
Give me the one-liner, the thing I should immediately think of when I see the word impetigo.
The honey-crusted contagion.
Okay, honey-crusted. That's the visual cue. Let's unpack the pathet here. I don't want just the visual yet. What is happening at the cellular level?
So you're usually dealing with Staphylococcus aureus or Streptococcus pyogenes. These are bacteria that naturally colonize our skin. They hang out on the surface and cause zero problems.
They're just part of the normal flora.
Exactly. They're fine. Until there's a breach.
The breach being the key. We aren't just talking about a massive cut, right? This isn't from falling off a bike.
No, and that's the exam trap. The breach is microscopic. It's a mosquito bite the kid scratched. It's a runny nose where the tissue got raw from constant wiping. It's a little patch of eczema. The bacteria finds that opening, dives into the epidermis, and releases toxins.
And those toxins are what caused the blistering. Is that the mechanism?
That's it exactly. The toxins break down the proteins that hold skin cells together, specifically the desmosomes. So the skin literally starts to separate. Fluid leaks out. That's your vesicle. And when that vesicle pops, the serum dries up.
Ah, so that's the honey.
That dried serum is what gives you that classic golden, honey-colored crust.
Okay, that makes the honey description surprisingly grosser when you know it's dried serum. But distinguishing this on an exam, is it always crusted? Or are there different types I need to watch for?
Great question, because you can get tripped up here. There are two types, non-bullous and bullous. The honey crust is the non-bullous type. That's the most common, maybe 70% of cases.
Okay, so what is bullous impetigo?
Bullous is exactly what it sounds like. Big, fluid-filled, glisters bully. These don't always crust immediately. They look like shiny, raw, red circles after they pop. It's often caused by specific toxin-producing staph.
I feel like that's a critical distinction because if a student is only hunting for the keyword crust, they might miss a case study describing a shiny, denuded red area on an infant.
Precisely. If you see bulo or varnish-like crust, you still need to be thinking impetigo. It's the same family of infection, just a different presentation.
And where do we usually see this? Anatomically.
Often around the nose and mouth. Think about toddlers. They're constantly wiping their noses, touching their faces. They create little microabrasions. The bacteria gets in and boom, honey crust.
So what's the need to know treatment? How do we fix this?
If it's mild and localized, just a few spots, we use a topical bacterial ointment, like mupirocin. We just put the medicine right on the lesions. But before you apply it, there is a nursing step that people often forget.
Oh, this sounds like a good test question. What is it?
You have to remove the crust.
Really? You have to pick it off?
You do. The crust is a barrier. It's like a shield. If you put ointment on top of a hard scab, it doesn't get to the bacteria underneath. You need to soak it with warm water and gently scrub it off.
Gently being the operative word. You're not trying to make it bleed.
No, not at all. Just soften and debride that superficial layer so the medication can penetrate.
Okay, so that's for mild cases. What if it's severe? Like it's all over their body?
If it's widespread, or if there is fever and lymphadenopathy, swollen lymph nodes, we move to oral antibiotics, usually a cephalosporin or amoxicillin clavulinate, something that gives good staph and strep coverage.
And for the parents? Because I imagine they freak out when they see this scabbing all over their kid's face. What's the key education point?
The biggest parent education point is hygiene. This is highly contagious. If that kid touches the crust and then touches another kid or touches a toy that another kid touches, it spreads.
What's that term for when they spread it on themselves?
Autoinoculation. They scratch their nose, then scratch their arm, and suddenly they have a new spot on their arm.
Right.
So hand washing is paramount. Keep the child's fingernails short so they can't scratch and spread it. They need to stay home from daycare or school for the first 24 hours after starting antibiotics.
Is there any good news for the parents? Something to calm them down?
Yes. A common fear is scarring. Parents see these nasty scabs on their beautiful baby's face and worry it's permanent. You can reassure them. Impetigo is superficial. It sits in the epidermis. It tends to heal without scarring. It looks worse than it is.
That's a huge relief for them, I'm sure.
Hmm.
Okay, let's move from bacteria to fungus. Topic 2. Fungal skin infections. The tinias.
We call them the tiniest. It's a fungus among us, differentiated by location.
I feel like ringworm is the term everyone knows, but it's kind of a misnomer, right? It's not a worm.
Completely. There is no worm. It's a dermatophyte, a fungus that feeds on keratin. Keratin is the protein in your hair, skin, and nails.
So it's literally eating the skin.
It is, and it grows in a circle, expanding outward as it eats the keratin in your skin. The center clears up because the fungus has moved on to fresher pastures at the edge, creating that classic ring.
That is disturbingly evocative. Fresher pastures. Let's run down the anatomy lesson because the Latin names tell you exactly where it is.
Right, so if you see tinea catus on an exam.
Hepatitis means head, so scalp.
Correct. Tinea cruris.
Cruris. Sounds like crutch. Groin. Jock itch.
Exactly. Tinea pedis.
Pedis is foot. Athlete's foot. Easy enough.
Tinea corporis.
Corporis means body, so arms, legs, trunk.
Yes, that's your classic ringworm presentation, the circular patch on the arm. And then tinea versicolor is specifically on the trunk and extremities, often looking like discolored patches, either lighter or darker than the surrounding skin.
Okay, let's talk treatment. This seems straightforward. Is it just put cream on it for all of them?
This is the exam trap, and it's a big one. For most tinea, like tinea corporis on the arm or tinea pedis on the foot, yes, you use a topical antifungal cream like clotrimazole or miconazole.
And there's a specific way to apply it, right?
Yes, you apply it an inch past the border to catch the spreading fungus. You're trying to create a firewall.
I hear a butt coming.
But tinea capitis on the head is different. Think about the anatomy. The fungus isn't just on the skin, it's down inside the hair follicle.
Oh, so a topical cream isn't going to reach it? It can't get down that deep?
Correct. Creams can't penetrate deep enough into the follicle bulb. So if a child has tinea capitis, we usually need oral systemic medication. Griselfulvin is the gold standard here.
Oral meds for a scalp rash? That's a massive distinction. So if you pick topical nystatin for tinea capitis on an exam, you are wrong.
You are wrong, and the patient won't get better. And clinically, tinea capitis can cause permanent hair loss if it causes a big, boggy, inflamed abscess. So we treat it aggressively from the inside out.
Okay, that's a huge clinical pearl. Oral meds for the head, topical for the body.
And sometimes we add a special shampoo, like selenium sulfide shampoo, to help decrease the fungal load on the scalp, but the shampoo alone is not enough. It's an adjunct to the oral therapy.
Got it. Okay, moving on to bucket 2. Inflammatory patterns. Topic 3 is a big one. Eczema, or atopic dermatitis.
The itch that rashes.
Wait, don't you mean the rash that itches?
No. And that's a crucial distinction in pediatrics. We call it the itch that rashes, because the itching often comes first. The child feels this intense pruritus itching, and they scratch. The scratching damages the skin barrier, and then the rash flares up. It's an allergic cycle. Scratching leads to rash, which leads to more itching.
That's a paradigm shift for me. So the itching is the cause, not the symptom.
In many ways, yes, the primary sensation is the pruritus.
Let's talk about the atopic triad. I see this term everywhere. What is it and why does it matter?
This is essential for history taking. Eczema rarely travels alone. It travels with two friends, asthma and allergic rhinitis or hay fever. If a kid comes in with severe eczema, you could be asking about breathing issues and allergies.
So if you see one, you should be looking for the others.
You should have a high index of suspicion. It's all the same underlying hypersensitivity, an overactive immune system.
Pathologically, what is wrong with their skin? Why is it so dry?
It's often a genetic defect in a protein called filigrin.
Filigrin?
Imagine your skin cells are bricks. Filigrin is the mortar that holds them together and keeps moisture in. In eczema, the mortar is crumbly. Water evaporates out. We call that transepidermal water loss.
Yeah.
And allergens get in.
So the skin is literally leaky? The barrier is compromised from birth?
Yes. It's dry, cracked, and defenseless against the environment.
So what is our priority intervention? If the problem is dry, itchy skin, how do we fix it? What's the 80-20 here?
Hydration and moisture preservation. That is the #1 goal. We have to seal the barrier.
How do we do that? The source material explicitly names some products here.
Yes, it mentions Aquaphor and Cetaphil. We need heavy, thick emollients. We are not talking about watery lotions that smell like vanilla.
Why not? Lotions seem like a good idea.
Lotions have high water content and can actually dry the skin more as they evaporate. It's counterintuitive. We need ointments, grease, petroleum-based products that create an occlusive barrier.
So grease them up.
Grease them up. Especially right after a bath, when the skin is still damp. We call it the soak and seal method. A short, lukewarm bath, pat dry, and then immediately slather on the ointment to trap that moisture.
What about medications? If the moisturizing isn't enough?
We attack the two problems, the inflammation and the itch. For inflammation, we use topical steroids during flare-ups.
Now, parents are often terrified of steroids. Steroid phobia. They think it will stunt the kid's growth or thin their skin instantly. How do you counsel them?
And that's a valid concern if misused. But as the nurse, you educate. We use the lowest potency that works only on the affected areas and only for short bursts like 1 to 2 weeks. We don't slather high-dose steroids on the face for months. It's about appropriate use.
So low and slow. And there's a mention of immunomodulators like tacrolimus. What's their role?
Right. Those are non-steroidal options. We use them specifically for sensitive areas like the face or eyelids where you want to avoid long-term steroid use, or we use them for maintenance to prevent flares.
And what about the itch? How do we stop that cycle we talked about?
Antihistamines, especially at night. Something like diphenhydramine or hydroxyzine can help break the cycle by reducing the itch and helping the child sleep.
I want to pause on the developmental impact here. Because eczema sounds annoying, but is it really a developmental issue?
Hugely. Imagine you are a 2-year-old. Your main job is to sleep and grow. But your skin feels like it's on fire. You itch constantly. You can't sleep.
And if you don't sleep?
If you don't sleep, you don't release growth hormone properly. You are irritable, you aren't playing, you aren't learning. Severe eczema can be a major disruptor to infant and toddler development strictly due to sleep hygiene and chronic discomfort. It affects the whole family dynamic.
That puts it in perspective. It's not just dry skin. It's a quality of life issue that has real developmental consequences.
Exactly.
Let's slide down to the other inflammatory issue. Diaper dermatitis versus candidiasis. This is the battle of the diaper rashes.
The common versus the yeast. Every parent deals with this at some point.
How do I tell them apart visually? What's the key finding?
Standard diaper dermatitis is usually erythema redness on the convex surfaces.
Convex, so the parts that stick out.
Exactly. The parts of the butt that touch the diaper. The cheeks. It spares the folds.
Wait, it spares the folds? That seems odd.
Usually, yes, because it's caused by friction and irritation from urine and stool. The folds are tucked away and protected from that direct contact.
Okay, so redness on the cheeks, but the creases look fine. And the treatment?
Barrier ointments. We need to put a wall between the skin and the diaper. Zinc oxide, vitamin A, D, E, petrolatum. You slather it on like frosting on a cupcake.
I like that visual. And you don't wipe it all off.
You don't scrub it off fully with every change. You just clean the soiled part and add more frosting. Protect that barrier at all costs. Airtime is also great. Let them run around without a diaper for a bit.
Okay, what about candidiasis? The yeast. How does that look different?
Candidiasis loves the folds.
Yeah.
Loves warm, dark, moist places. So if the redness is deep in the inguinal folds, you should suspect yeast.
So it's the opposite of the standard rash.
Exactly. And what's the hallmark visual finding?
This sounds like a test question.
It is. Satellite lesions. This is the buzzword. You have the main beefy red rash and then little red dots scattered outside the main border. Like satellites orbiting a planet. If you see satellite lesions, it's yeast.
And barrier cream won't fix yeast.
Correct. You're just trapping the yeast under a layer of ointment. You need an antifungal, nystatin or clotrimazole. The source explicitly separates these because the treatment path is totally different. If you treat yeast with zinc oxide, it won't go away and the parents will be back in 2 days.
Got it. Okay, let's graduate from babies to teenagers. Bucket 3, hormonal patterns. Topic 5, acne vulgaris.
The adolescent rite of passage.
The source material emphasizes that this is exclusively discussed in the context of adolescence.
Which makes sense physiologically. Puberty hits, androgens, the male hormones, surge in both boys and girls.
Yeah.
Those androgens tell the sebaceous glands to go into overdrive, and you get acne.
And developmentally, this is massive. This isn't just a cosmetic issue.
It is absolutely not. Adolescence is all about identity formation, body image, and peer acceptance. Acne strikes right at the center of their vulnerability. A bad breakout can lead to social withdrawal, depression, anxiety. It's never just a pimple to a teenager.
So how do we treat it? I see a treatment ladder here in the outline.
Think of it as steps. We start mild and get heavier. Step 1 is hygiene. Gentle cleansing, twice a day.
The text says mild cleanser. Why not scrub it? I feel like the instinct is to scrub the grease off.
That's the wrong instinct, and it's a common mistake. Scrubbing irritates the skin, causes more inflammation, and can actually stimulate more oil production as a rebound effect. We want gentle cleansing to remove the surface oil without destroying the skin's natural barrier.
Okay, so no harsh scrubs. Step 2 on the ladder.
Topicals. We use retinoids like tretinoin to help turn over skin cells so pores don't clog, or benzoyl peroxide, which is an antibacterial agent, to kill the P. acnes bacteria that contributes to inflammation.
So you're unclogging and killing bacteria at the same time.
Ideally, yes. Sometimes we use them in combination.
Step 3. What if the topicals don't work?
If topicals don't work, we add systemic antibiotics, the sourceless tetracycline. This is an oral pill to fight the infection and inflammation from the inside out.
And if all that fails, the kid is still miserable, they're getting scars, we bring in the big guns.
Isotretinoin. Brand name Accutane, though there are many generics now. This is reserved for severe nodulocystic acne that is scarring and resistant to everything else.
All right, let's climb the ladder to the top rung. We've tried the special soaps, we've tried the creams, we've even done the oral antibiotics. The kid is still suffering. We bring in the nuclear option.
Isotretinoin is a miracle drug for acne. I mean, it really can be life-changing. But it is the highest maintenance drug in dermatology.
The source material highlights boxed 23.2 for Accutane. Whenever a textbook puts a black box around something, I pay attention. What is the absolute red flag do not pass go risk here?
Teratogenicity.
Meaning birth defects.
Severe life-altering birth defects. If a female patient takes this drug while pregnant or becomes pregnant while on it, the fetal outcomes are catastrophic. Craniofacial abnormalities, heart defects, brain malformations. It is incompatible with a healthy pregnancy.
Which leads to the IPLGG program. I remember this being a huge logistical hurdle in the clinic. Can you explain what that is?
It is, but it's necessary. You cannot just write a script. The patient, the provider who prescribes it, and the pharmacist who dispenses it all have to be registered in a federal database.
Everyone has to be in the system.
Yes. And clinically, what does that look like for the nurse? You aren't just asking, are you pregnant?
No, I imagine it's more involved.
Much more. You need proof. 2 negative pregnancy tests before you even start the first dose. A negative test every single month before a refill can be dispensed. And usually, a requirement for 2 simultaneous forms of birth control.
2 forms, so the pill plus condoms. Or an IUD plus condoms.
Exactly. Redundancy is key. And here is where the art of nursing comes in. You are having this conversation with a 16-year-old girl, maybe with her mom in the room. It can be awkward.
Extremely. How do you navigate that?
You have to be fearless and non-judgmental. You have to advocate for that safety protocol because the alternative is tragic. You explain the risks clearly, you assess their understanding, and you document everything.
Is there a mental health component too? I feel like I've heard about mood changes.
There is. It's controversial in the data. Some studies show a link, some don't, but the protocols are clear. Monitor for depression and suicidal ideation.
But isn't the acne itself causing depression?
It is. That's the confounding variable. Does the drug cause depression, or does the drug fail to relieve the depression caused by the acne fast enough? Regardless, our job is to monitor. So you are monitoring the skin, the womb, and the brain.
Wow, it's a heavy-duty medication.
It absolutely is.
All right, we have arrived at the final bucket, the most critical section of this entire deep dive. If you are listening to this on your commute, turn the volume up. Bucket 4. Trauma, specifically burns.
This is the section where skin issues stop being dermatology and start being critical care. A severe burn is a full-body insult.
You called it systemic trauma earlier, but a burn is on the skin. Why is it systemic? What's the mechanism?
Because the skin does so much for us. It keeps fluids in, it keeps heat in, it keeps bacteria out. When you burn a large percentage of a child's body, all those systems fail at once. You lose fluid, you lose heat, you invite infection.
But there's more to it than that, right?
Much more. The burn releases a storm of inflammatory mediators, cytokines, that cause blood vessels all over the body to dilate and leak.
So even if the burn is just on the legs, the blood vessels in the lungs or the arms might start leaking.
Exactly. It's a systemic inflammatory response syndrome, or SIRS. The whole body is on fire, metaphorically.
The outline gives us a very specific need-to-know list for emergency assessment priorities. It's the ABCs, but tailored for burns. Let's walk through them in order because the order matters for the exam.
Airway is always king. Always. But in burns, the threat is insidious.
What do you mean by insidious? It's not obvious.
Well, if a kid breaks their leg, the leg is broken, you can see it. In a burn, specifically with smoke inhalation, the damage is internal. You might look at the child and they seem fine. They were talking to you. But 5 minutes later, their airway has swollen shut due to edema from the heat and soot.
That is terrifying. So what are the clues? If I can't see the swelling yet, what am I looking for? What are the red flags for airway involvement?
You are looking for the evidence of the fire on the face, singed nasal hairs, soot around the mouth or in the sputum, burns on the neck or face, and listen to their voice. Any hoarseness is a major red flag.
And if I see those, what's a move?
You assume the airway is compromised until proven otherwise. You don't wait for them to start gasping or for their oxygen saturation to drop. We often intubate these kids prophylactically early.
Better to intubate early than try to shove a tube through a swollen throat later.
100%. Once that airway swells, it can be impossible to get a tube in. So, secure the airway. That's priority number 1. Now, once the airway is secure, we move to the other silent killer. Priority 2, fluid volume.
Hypovolemic shock.
Right, and this is pure physics. The skin holds our water in. You burn the skin, the water evaporates. But it's worse than that. We talked about those leaky capillaries. Fluid rushes out of the blood vessels and into the tissue. We call this third spacing.
So the patient looks puffy and swollen, but their blood vessels are empty.
Exactly, it's a paradox.
Yeah.
They are edematous, but their blood pressure is tanking because the tank is empty. The heart has nothing to pump. This is burn shock.
And kids are at higher risk for this than adults, right? Why is that?
Yes. Kids have a larger body surface area relative to their weight. Think of a baby's head. It's huge compared to its body. They have more skin per pound, so they lose fluid much, much faster.
This brings us to the Parkland formula. I know we aren't doing math on a podcast, but conceptually, what is the goal here?
The goal is aggressive replacement using lactated ringers. We are pouring fluids in to keep up with the leak. The formula gives you a target volume to infuse over 24 hours, with half of it going in during the first 8 hours.
But, and here's the pediatric nuance, you can't just open the fire hose.
You absolutely cannot. Kids have tiny hearts and a fixed stroke volume. If you flood them with fluid too fast, you send them into pulmonary edema, you drown their lungs. It is a tightrope walk.
So how do you know if you're giving the right amount?
You titrate the fluids based on urine output.
Urine output is the speedometer.
Exactly. If they are making adequate urine, which for a child is about 1 milliliter per kilogram per hour, then the kidneys are happy. If the kidneys are happy, it means they're getting enough blood flow, which means the heart is pumping effectively. It's our best real-time indicator of organ perfusion.
Okay. Airway, then fluids. Priority 3.
Hypothermia. Again, skin keeps us warm. A burned child has no insulation. They lose heat rapidly to the environment.
And getting cold is bad for more than just comfort.
It's deadly. If they get cold, their clotting factors stop working and they can start bleeding. Their metabolism crashes. You have to keep them warm. Crank the room heat, use warm IV fluids, use warming blankets.
Priority 4.
Infection. The barrier is gone. Sepsis is a huge risk, but it's usually a later complication, not an immediate one.
Right.
This is why we use sterile technique for dressing changes and monitor for signs of infection down the line.
And finally, the last 2 pieces.
Pain management and nutrition. Pain is obvious. Burns are excruciating. We use IV opioids. Never IM injections in a burn patient.
Why no IM shots?
Because absorption is totally unpredictable in that edematous third-spaced tissue. You might give a shot and it just sits there. Then suddenly it all gets absorbed at once. FOIV is the only safe way.
And nutrition.
A major burn puts the body into a hypermetabolic state. The body is burning calories like crazy trying to heal and stay warm. They need massive nutritional support, high protein, high calorie, to rebuild that tissue. If you don't feed them, they won't heal.
So for the exam, airway first, always. Check for soot, singed hair, then fluids using the Parkland formula and watching urine output, then temperature, then later, infection, pain, and nutrition.
That is your roadmap.
Yeah.
If a question asks what is the nurse's priority action for a child with facial burns, the answer is assess airway, not start an IV. Airway first.
Got it. Okay, let's move into section C, the medication module. We've touched on some of these, but let's do a rapid-fire review of the specific drugs mentioned in the source material. I want the pearls, the specific nursing considerations.
Let's do it.
Category 1, acne management. We talked about retinoids like tretinoin. What's the pearl?
The pearl is photosensitivity and time. These take 4 to 6 weeks to work, and they make the skin burn easily. Parent teaching. Wear sunscreen and don't give up after week 1. It might get worse before it gets better.
Benzoyl peroxide.
It bleaches everything. It bleaches towels, pillowcases, shirts. Tell the teen. Use an old white towel or your mom's going to kill you for ruining the fancy linens. It's a real-world tip that improves compliance.
Good practical tip. Systemic antibiotics like tetracycline.
Used for resistant acne. The pearl here for pediatrics, and this is a general rule, is to be careful with age. Tetracyclines can stain developing teeth gray or yellow.
Permanently.
Permanently. So we usually reserve them for children over 8 or 9 years old once the permanent teeth are fully calcified.
Okay, category 2. Eczema management. Topical immunomodulators like tacrolimus.
The pearl is that it is a non-steroidal option, great for phases. But it can burn or sting when first applied. You have to warn the parents so they don't think the child is having an allergic reaction to the medicine and stop using it.
Topical steroids.
Potency matters. Avoid the face and diaper area if possible, or use very low potency. Thin skin absorbs too much. The side effect to watch for long-term is skin atrophy, which is thinning, and striae, or stretch marks.
Antihistamines like diphenhydramine or hydroxyzine.
Crucial distinction. Antihistamines treat the symptom, which is the itch, not the rash itself. They help the child sleep and break that itch-scratch cycle. Side effect in kids. Sedation is common, but watch out for the paradoxical effect.
Where they get hyper instead of sleepy.
Exactly. Instead of calming down, they're bouncing off the walls. You need to warn parents that this can happen.
Category 3. Anti-infectives. Grisafulvin.
Oral antifungal for tinea capitis. The pearl is absorption. It is insoluble in water. It needs fat to be absorbed.
So take it with what?
A fatty meal. Whole milk, ice cream, peanut butter. If you give it with water or juice on an empty stomach, it won't work. The patient won't get better.
That's a great tip. Take your medicine with ice cream. I bet compliance goes way up with that instruction.
It definitely helps. And one other thing, you need to monitor liver enzymes, the LFTs, if they are on it for a long time, as it can be hepatotoxic.
Good to know. Okay, we are in the home stretch. Section D, cross-linking and synthesis. Let's connect some dots here. Bring it all together.
The biggest connection I want listeners to make is the scratch infection cycle.
Walk me through it. Connect the dots for me between the different buckets.
Okay, so we talked about eczema. That's an inflammatory condition. It itches, the child scratches. Now you have an open wound, a breach in the barrier. What lives on the skin?
Staph bacteria.
Staph bacteria. The staph gets in the open wound, and now you have impetigo, an infectious condition on top of eczema. This is called a secondary infection.
So treating the itch isn't just about comfort, it's about infection prevention.
Exactly. Giving that antihistamine for the eczema prevents the scratch, which prevents the impetigo. It's all connected. You're treating the inflammation to prevent the infection.
Another theme I'm seeing is the barrier theme. It keeps coming up.
It's the central theme of pediatric dermatology. Whether it's diaper dermatitis, where we use zinc oxide, or eczema, where we use Aquaphor, or burns, where we use dressings, the nursing goal is always restoring the skin barrier. The skin is the castle wall. If the wall is breached, the enemy gets in. Our job is to patch the wall.
And finally, let's talk about the adolescent compliance piece. This seems to cross over from acne to other things too.
It's huge for acne. The treatment's retinoids, antibiotics, require long-term daily compliance. But adolescents are developmentally notorious for poor compliance. They want instant results.
And these things don't work instantly.
Not at all. When the cream doesn't fix their face in 2 days, they stop using it. Or they get frustrated and use way too much and burn their face, and then they stop using it.
So nursing care involves a lot of expectation management. It's more coaching than just giving instructions.
Exactly. You have to say, this will take 6 weeks to see a difference. It might look worse before it looks better. You have to keep doing it every single day, even when you don't see results yet. Coaching the teen is just as important as writing the prescription. You have to treat them like a partner in their own care, not a child you're ordering around.
This has been a fantastic run-through. Let's do the final tally. If you could only remember a few things from today for an exam, what are the big takeaways?
Okay, the rapid-fire summary. Visuals. If you see honeycrest, think impetigo. If you see satellite lesions, think yeast. If you see a ring with a clear center, think TINA.
Got it. Emergencies.
If you see burns, think airway, looking for singed hair or soot. And fluids, thinking Quarkland formula and urine output, those come first, before anything else.
And meds, the big one.
If you see Accutane or isotretinoin, think safety, think pregnancy prevention, and think mental health monitoring.
Short, sweet, and saves lives. I want to leave the listeners with a final provocative thought. Something to chew on.
Okay, we spend a lot of time looking at the surface. Rashes, burns, pimples. But in pediatrics, the skin is just the messenger. My thought for you specifically on burns. We treat the skin, but the killer is often what we can't see.
The insidious part you mentioned earlier?
Exactly. It's the airway swelling shut inside the throat. It's the fluid leaking out of the vessels inside the body causing shock. In pediatric burns, you must look past the surface immediately. Don't get distracted by the gore of the wound itself. Focus on the invisible physiology that keeps them alive. That's where you'll save a life.
That is a powerful place to end. Whether you are walking into an exam tomorrow or walking onto the unit, keep your eyes open, check that check engine light, and trust your assessment. Thanks for diving in with us.
Good luck out there. It was a pleasure.
See you next time.